Niacin and statins, though often discussed in separate contexts, may in fact represent complementary arms of a more holistic strategy to manage atherosclerosis. Statins, the current gold standard in lipid-lowering therapy, work by inhibiting HMG-CoA reductase in the liver, thereby reducing endogenous cholesterol synthesis and increasing LDL receptor expression to clear circulating low-density lipoprotein (LDL) particles. This mechanism has been highly effective in lowering serum cholesterol and reducing cardiovascular events. However, despite aggressive statin therapy, many patients continue to experience atherosclerotic progression and cardiovascular events, a phenomenon known as residual risk. This is where niacin's unique intracellular effects may offer a synergistic advantage. Unlike statins, which act predominantly at the hepatic level, niacin operates within peripheral cells, particularly macrophages, to regulate intracellular cholesterol handling. Niacin stimulates cholesterol efflux from lysosomes by activating CD38, which increases the synthesis of nicotinic acid adenine dinucleotide phosphate, (NAP), a signaling molecule that promotes calcium release via lysosomal TRPML1 channels. This calcium signal upregulates liver X receptor alpha, LXRA, which in turn increases the expression of cholesterol transporters such as Niemann-Pick C1, NPC1, ABCA1, and ABCG1. These proteins facilitate the movement of free cholesterol out of lysosomes into the cytoplasm and eventually out of the cell, either for storage as cholesterol esters or for reverse transport back to the liver via high-density lipoprotein, HDL. This cellular clearance of cholesterol is critical in the context of atherosclerosis, where macrophages engulf oxidized LDL and become foam cells. Accumulation of free cholesterol in lysosomes not only contributes to foam cell formation but also triggers inflammation and cell death, both of which drive plaque instability. Niacin's ability to promote lysosomal cholesterol efflux and reduce pro-inflammatory cytokine secretion, notably IL-1S, addresses these issues directly at the plaque level, something statins do not specifically target. The complementary nature of niacin and statins becomes even clearer when considering their respective strengths. Statins dramatically reduce circulating LDL, lowering the input of cholesterol into the vascular wall. Niacin, by contrast, supports the exit of cholesterol already inside vascular cells and prevents the downstream inflammatory cascade. Together, they create a bidirectional approach. Statins reduce delivery of cholesterol to atherosclerotic sites, while niacin facilitates removal of trapped intracellular cholesterol and mitigates its harmful effects. Furthermore, niacin enhances HDL function by upregulating ABCA1 and ABCG1, facilitating reverse cholesterol transport. Although statins may modestly increase HDL levels, they do not significantly enhance HDL-mediated cholesterol efflux. Niacin, therefore, fills this functional gap, improving cholesterol recycling from peripheral tissues to the liver, a process essential for long-term atheroprotection. This synergy also extends to inflammation, a key driver of atherogenesis. While statins have some anti-inflammatory properties, niacin directly suppresses IL-1S secretion and reduces macrophage apoptosis in the plaque environment. This unique anti-inflammatory effect is particularly relevant in advanced lesions where inflammation rather than lipid accumulation becomes the dominant risk factor for plaque rupture and thrombosis. Taken together, niacin and statins offer non-overlapping mechanisms that, when combined, may produce additive or even synergistic effects on plaque regression and stabilization. Statins reduce lipid influx and systemic cholesterol burden, while niacin enhances cellular cholesterol clearance, reduces inflammation, and protects macrophages from foam cell-related death. In clinical practice, this combined approach could be particularly valuable in high-risk patients with persistent inflammatory or metabolic dysfunction despite optimal statin therapy. While concerns about niacin side effects, such as flushing and hepatotoxicity, have limited its recent use, these adverse effects may be manageable with dose adjustment or flushing reduction strategies, and newer formulations may offer improved tolerability. In summary, niacin and statins do not compete, but rather complement each other in the fight against atherosclerosis. By targeting cholesterol metabolism at different physiological levels, hepatic production versus cellular clearance, They form a coordinated defense that addresses both lipid burden and inflammatory damage within the arterial wall. This integrated approach holds promise for reducing residual cardiovascular risk in ways that monotherapy cannot fully achieve.